Alright, this is Trevor Adams with Cat 3 video. So first we're going to do a SOAS. So Chris, I'm going to have you bring out like this. Good. Contraction. And then stretch your fingers out. Good. Alright. So looks like the left is short, so what we do is come inside our patient and have you bend this knee like that. Good. And come onto the psoas, and then as you breathe in, I'm going to take this out, and when you breathe out, bring it back to your face. So go ahead and take a breath in. Good. Breathe all the way out. Bring that in. Press down. Go again. Maintain my contact there. Go a little bit further this time. One more time. Pressing in and goating it around that last time. Good. Go ahead and bring your hands up. We'll recheck. Yeah, it looks like that helps pretty good. All right, so go ahead and flip over for me, Chris. So next thing would be the prone leg length analysis. So what we do is first take it up 14 inches. So I'm gonna have you resist, Chris. Good. Relax. Looking at the medial malleolus. So after looking at the medial malleolus, the right is the short leg. So from there we'll go to glute fiber analysis, and so we're going to start on the PSIS. So we'll just be looking at say the left side first, but area 5 would be at the PSIS, and then we'd be going up the iliac crest. 5, 4, 3, 2, 1, and what I would do is I'd see if any of those were tender, and then I'd do the 5 areas, start at the right PSIS on the right side, compare the two, see which one, see if there was one side that was had one spot that was more tender. So say it was 5 on the right, then we'd come to L5 and test for tenderness there, and then using the Levitt brothers relationship, test L1 or C1 up top for tenderness. And then whichever one of those is more tender, we'd use that information as we evaluate further. So that's for that. The next thing we do is look at the indicators, and so that's going to be usually on the side of the sciatic pain. So say it's the left side. First we'd come and just along the calf muscle, see if that causes any pain or tenderness. And then along the hamstring, see if there's any pain or tenderness there. Then the glutes. And the last would be the temporosphenoid line on a patient. Okay, so that's the indicators. And then the last thing we do is going to be the SOT. So say we'll just stay along that left side. So what I'm going to do is I'm going to have my one hand underneath the proximal knee, the other one top of the ankle, and take out the leg until the glutes start to bunch up. Then we're going to take the toe out, hold that for 15 seconds, take it back in, and then wait for 2 minutes, okay? And then we're going to take it back out until it bunches. It's right there. Take toe out for about 15 seconds again, so 15. Then come back, and then I would ask the patient how the two compare to each other. So if it got better, then that means that there's a piriformis problem on the side. If it stayed the same, then we know that there's a disc herniation or a subluxation. And then if it got worse, then we know it would be a sequestered disc in that area. And that's it. So first we're going to do a prone leg length analysis again to just identify the short leg. Press it out. Relax. So the patient has a right short leg, so for category 3 blocking, the patient will be prone. And the indication for category 3 is just that there's pain, and the goal of category 3 is to reduce the pain. And so for short leg, you'd be on the right. I'm going to place the first block, and patient will have the pelvic pad, iliac crest 4 inches above or below the top of the pelvic pad. Is your knees okay? Okay. So first one, bring it up here to the trochanter. It's going to be 45 degrees inferior and oblique. And for the long leg, it's going to be at the ASIS 45 degrees inferior and oblique as well. Is this knee okay? Okay, and the max time of category 3 blocking is for up to 30 minutes. Okay, so the next step would be the block augmentations. So the first one is the posterior iliofemoral ligament. And so what I'm gonna do is I'm gonna internally rotate the legs to see if there's any restriction. So say that the right is slightly restricted with internal rotation. So I'm gonna come an inch above and an inch posterior as well as an inch superior to the greater trochanter and apply double thumb toggle. Line of drive is towards the opposite obturator foramen. And if this block was happening to be in the way, then I could remove the block for the augmentation of this move. So the next one will be the lumbar vertebral derotation. So we'll say that the right side is the involved side. So using the cervical indicators to find the lumbar that's problematic, and it's not rotating. So what we would do is flex this knee towards the glute, and then using that cervical indicator, find which lumbar is problematic. So we'll say it's L4, and we can apply a lateral to medial line of drive through that lumbar, trying to provide some rotation there. Okay, so next step is the lumbar inferiority lift. So it'll be very similar to the derotation move. Patient will be tractioning from the head of the table like they should on all of the augmentation moves. So we'll say the right side is the involved side. And we'll say, using the cervical indicators, that L4 was the one of inferiority on the right. So take that involved side leg and gonna press in, and at the same time come on the mammillary process of L4, and I'm gonna have you breathe in, and I'm gonna press in as they breathe in, this ankle down, as well as pressing superiorly with at the L4 mammillary process. The next would be the acetabular goading. So same thing, patient's still blocked, they're gonna be tractioning. I'm gonna bring this leg up. I'm just gonna feel around for any tenderness or nodules around the acetabulum, and once they're there, just kind of goad them out and get those nodules out of there. And that's it for the acetabular goading. Okay, so next would be the augmentation, the orthopedic blocking. So this is done to derotate vertebra. So what you do is you pull the block on the side of spinous rotation. So we'll say it's the right side. Just pull this block. And then that's going to naturally just derotate the spinous. So we'll put this back in. Okay, so next thing would be the sciatic traction. And the indicator for this is if the patient has sciatica. And so same thing, patient's going to traction from the head of the table. I'm going to come to the involved side, say it's the right side. And I'm going to have you traction. I'm going to pull the leg inferiorly and hold for 5 to 10 seconds. And then this is done and repeated until there's no pain or there's no more improvement in the pain going away. After that, you could do the assisted sciatic traction, which it'd be very similar to the regular sciatic traction, except an assistant would pull the leg, the involved side leg, at the same time when the doctor says so. The doctor would come onto the spinous, the inferior portion of the spinous, and then on the doctor's go, the patient tractions, the doctor or the assistant pulls the involved side leg, and the doctor presses I to S at the spinous process of the involved area. Okay, so after the block augmentations, move into the sacral base analysis like we've done before. So for this one, the patient's still on the blocks. The same thing like we've done. Put the thumb on the L5 spinous, have the patient cough. And so if the thumb goes towards the ceiling, then it's sacral base positive. If it goes towards the head, it's negative. And if it goes In between that at an angle, then it'd be sacral base neutral. And so then you would realign the blocks based on the finding that you get. And then from there you would, for like sacral base positive, you're gonna be on the apex. And as they inhale, you're gonna press down. Sacral base negative, as they exhale, you're gonna be on the base and you're gonna press down on the base. And then if it's sacral base neutral, then you're gonna be on both apex and the base, and just going back and forth as they inhale and exhale. And then after that, we would check the sacral cups. So since they're prone, what we would do, we would remove the blocks. We're going to take these out. So remove the blocks and just check for sacral cups. So I have you bring your leg up and hold. Good. And then same side, the same thing on the other side. Hold. Good. And then based upon what we find there, we'd use the sacral bait or sacral cup techniques like we've done before. Okay, so next step would be the sitting disc. So for this one, the patient will be seated. I'm going to have you tuck your chin to your chest. I'm going to apply, or as they bend forward, I'm going to have them inhale. So go ahead and bend forward and inhale. And the doctor's going to apply I to S pressure, and then exhale and come up. And then P to A pressure as they exhale and come back up. And then go back down, I to S pressure as they're inhaling and moving forward, or bending forward again. And you repeat these 3 steps to just help reduce the pain. And you want to make sure that the patient has their chin tucked to their chest the whole time. So next thing would be the side posture. So Parker, I'm going to have you come on your side and face me, so go on your left side. So for this, a couple things to remember: the sciatic side is down, and then the TVP inferiority is down as well. And so just like we've learned, side posture here, give a nice relaxed position, and contact will be the mammillary process. And if it's for a rotation, it's going to be P to A at the mammillary process, and if there's inferiority, then you can go I to S on that as well. And that's the side posture.